and welcome to PodcastDX, the show that brings you interviews with people just like you whose lives were forever changed by a medical diagnosis. I'm Lita.
I'm Jean Marie.
And Ron's not going to be with us today. Today we're talking about something that shapes mental health care behind the scenes, but doesn't always make it into everyday conversation. The Diagnostic and Statistical Manual of Mental Disorders, or the DSM. This episode is called Rethinking Diagnosis, a Digital DSM and the Roots of Mental Health. We'll talk about what the DSM is, how a future digital DSM-6 might look, and how new science around environment, trauma, inflammation, and nutrition is pushing psychiatry to look beyond symptoms alone.
For people who aren't working in the mental health world, what exactly is the DSM and why is it such a big deal? And why would a digital DSM be a big deal?
Well, the DSM is the main handbook that U.S. mental health professionals use to define and diagnose mental disorders. It lays out the official names, descriptions, and criteria for conditions like, depression, PTSD.
For diagnosing them, yes.
Right,
okay.
Right. Conditions like depression, PTSD, bipolar disorder, schizophrenia, ADHD, and many others.
And it's published by the American Psychiatric Association, and currently it's in version 5. Updates, such as the DSM-5-TR, is what's currently in use, and the DSM affects how clinicians document diagnoses, what insurance will cover, how research studies define who qualifies for a trial, and even how people understand their own experiences and identify with certain conditions.
So it's like a guidebook.
Mm-hmm.
So when we talk about how the DSM might change in its next edition, we're really talking about how we name and organize mental health in medicine, and that has very real consequences.
Recently, the American Psychiatric Association released a kind of a roadmap for the future of the DSM, and a lot of it is about going digital.
Yes, and instead of waiting many years between big paper editions, they're talking about a digitally native DSM that can be updated more continuously. And that means changes to criteria could be rolled out more quickly as evidence accumulates. It could mean clinicians could access interactive tools, decision aids, and links to treatment guidance. And also, data from real-world practice might feed back into how diagnoses are defined.
And right now, people can already submit proposals online to change how, diagnoses, details about mental health diagnoses, add specifiers, or even clarify wording for updates. And these proposals are reviewed by the DSM steering committee and expert working groups with posted proposed changes so that the field can see what's under consideration.
Well, that's kind of nice, working both ways.
Mm-hmm.
The future vision is that the DSM becomes a living document, still vetted and evidence-based, but more responsive and easier to integrate with electronic health records and digital tools.
Historically, the DSM has focused on describing symptoms and course of treatment. Like 5 of those 9 symptoms, that the patient has exhibited for at least 2 weeks, that sort of a thing. What's changing in how people think about mental health issues?
Well, there's growing recognition that mental health is shaped by multiple layers. One would be biology, so genes, brain circuits, hormones, inflammation. Another one would be environment and social determinants like poverty, discrimination, trauma, access to care, and community support. Another one would be culture and upbringing, how emotions are expressed, what counts as a symptom. And lastly, life stage, from children to adolescents to adults to older adults
Mm-hmm.
may show different patterns.
Okay. And recently, the American Psychiatric Association and research research has documented and emphasized that social determinants, mental health, especially in children and young adults, may include things like housing instability, community violence, racism, and education or the lack of educational opportunities available to them. And these factors aren't just, in the background. They're active contributors to who develops or who may develop what symptoms and how severe they may become if you're not, provided with the key elements that you need as a child, to a safe, positive environment, then it can affect your mental health.
Yeah, that reminds me. I think the number of homeless youth and children has risen dramatically.
Right, displaced families.
Yeah. There's also more attention to cultural concepts of distress, ways that different cultures understand and express suffering, which may not fit neatly into Western diagnostic boxes. A digital DSM could, in theory, link symptom criteria to contextual information like common cultural syndromes, social risk factors, and developmental considerations. So clinicians don't look at symptoms in isolation.
And let's talk about another one of the root causes of, or potential causes of mental health issues, trauma, especially in childhood.
Well, yeah, there's been large studies that have shown that childhood trauma, including abuse, neglect, household dysfunction, or exposure to violence, is strongly associated with a higher risk of depression, anxiety, PTSD, substance use disorders, and functional problems in their adulthood. The more severe and chronic the trauma, the greater the risk for later mental and physical health issues.
And researchers are talking about trauma-informed approaches for mental health care. And that doesn't just count on, the symptoms, but it asks, what may have led to this, what has happened to you in your past, and look at that as part of the overall mental health assessment. And future DSM versions may place more emphasis on trauma-related specifiers or cross-cutting assessments that, highlight trauma across multiple diagnoses, and, that would be a more informed diagnosis. So it wouldn't just be for people who have possibly PTSI or something of that nature, but, could cover multiple different mental health conditions.
And that could also help clinicians recognize when depression, anxiety, or attention problems are happening in the context of significant early adversity and tailor the care that addresses both symptoms and safety, coping skills, and social supports.
Yeah, I think all of us, coping skills seems to be something that everybody really. Another area of research that keeps coming up associated with mental health is inflammation. Let's dive into that a bit.
Okay. A number of the reviews that we've found that some people with depression and other mental health conditions have elevated markers of systemic inflammation, such as C-reactive protein or certain cytokines. Inflammation may change how brain circuits function, affect neurotransmitter systems, and contribute to symptoms like low mood, fatigue, and brain fog.
And that would be informing how that mental health condition or those mental health symptoms are treated and addressed. So it's a different approach.
Okay.
Researchers are exploring immunopsychiatry, studying when anti-inflammatory approaches might help a subset of patients and how chronic conditions like autoimmune disease or, for example, obesity interact with mental health. And we're not just, we're not at, that point where the DSM says, inflammatory depression as an official diagnosis, but future versions may include more guidance on, for example, including medical workups or consulting the primary health care provider and coordinating care. And then also that comorbid physical illnesses and biological markers might come into play when assessing and diagnosing and treating a patient for their who's living with certain mental health conditions.
Well, the big takeaway is that the line between physical and mental is not as sharp as older models suggested. A more modern digital DSM could better reflect that mind-body connection and prompt clinicians to think about both sides. But then does that mean the psychiatrist is going to act more like a GP, or the GP is going to act more like a psychiatrist?
What, or are you just bringing in your medical records into your mental health care?
Okay.
And also maybe it'll give you a sense that you can have a more active role in your mental health care. For example, let's talk about another factor, what we eat.
Right. Harvard's nutritional psychiatry work and other reviews highlight that diet patterns are linked to mental health. Diets that are rich in whole foods, like vegetables, fruits, whole grains, fish, olive oil, nuts, they have been associated with a lower risk of depression, while highly processed diets that are high in sugar and unhealthy fats, are associated with a higher risk of depression.
And so if you're, displaced and don't have, the opportunity or the ability to consume these, well-known whole foods or, a nice, happy, healthy diet, I of course, if you're depressed because you're displaced, and then that kind of feeds into, makes it worse and worse. So providing having adequate access to fresh fruits and vegetables, whole grains, fish, nuts, and olive oil and things of that nature, that's something that we may have to help support and add to, make that available.
Yeah, I think we talked about food scarcity and
in the past.
Yeah, about a different episode, but it comes back.
It does. And the idea that food affects the brain through multiple pathways, for example, inflammation and oxidative stress, the gut microbiome can have an effect, and that communicates with the brain. Blood sugar regulation, if your blood sugar is too high or too low, you're not going to feel good.
Right.
Your
body's stressed at that point.
Availability of key nutrients like omega-3s, B vitamins, and even minerals. That all comes into play with your mental health.
Well, again, the DSM doesn't become a nutrition manual, but future versions could encourage a more holistic assessment, reminding clinicians to consider diet, activity, and sleep as part of mental health evaluation and management, not just a side note.
Another thing emphasized in setting up this topic is that patients and families should always be part of shaping what is next and what's included in the DSM, because who knows a mental health condition better than those that are personally experiencing it and those who are living with those who are personally experiencing it on a day-to-day basis, not just researchers and committees and mental health care providers, but those who are actually are living with it.
Right. The APA, the American Psychiatric Association, has opened up formal channels for public and professional input. Clinicians can submit proposals online, and the roadmap discusses including people who, with a lived experience, like you were saying.
That's a great way to put it, lived experience.
Right. Or caregivers, those that are, and family members that are living with them, more systematically in the process. That includes people at different life stages, children, adolescents, adults, and older adults, and from diverse cultures and communities.
That's fantastic. I mean,
it's like the medicine of the future, and it's a good change.
Yeah. Lived experiences can highlight things that symptom checklists may miss. For example, how a diagnosis affects identity and stigma and how to handle those, because, that is part of the mental health care big picture. What kinds of language feel validating versus pathologizing or just, it's So that comes into play too. And I think that over the years, things have changed how we address things, homeless versus displaced, and how people view their
person with a disability rather than disabled.
right. So how it affects the individual. So that can be updated on a regular basis to keep up with times. How symptoms actually play out in real life situations, in real families, in the workplace, and in our personal relationships.
Right.
And as we said, different age, stages along the aging continuum. It can, symptoms and models for treatment may adjust.
Good point. Well, future DSM development may rely more on patient-reported outcomes, large-scale surveys, and ongoing dialogue with advocacy groups, not just academic panels. That could help ensure that diagnostic categories don't just make sense in theory, but genuinely help people get the right care.
So let's imagine for a moment a big fluffy cloud. No, what it might feel like to visit a clinician using a fully digital, updated DSM in the future.
Oh, that'd be interesting. Let's see. Let's picture, you might see the clinician using a tablet or computer interface that walks through the symptom criteria in plain language, that prompts them to ask about social determinants, trauma history, physical health, and substance use, flags when certain medications or medical conditions could be contributing to symptoms. I like that one. And it could also suggest age-specific considerations. So if you're a child, an adolescent, adult, or older adult, the treatment may be different.
Okay. And it might offer culturally sensitive questions, for example, and highlight when a person's experience doesn't, fit into one category. And flagging other specified or unspecified options, and then cautioning against over pathologizing normal reactions, for example.
And on the back end, anonymized data could help researchers refine criteria, seeing which clusters of symptoms and contexts tend to go together, and which labels are actually useful in predicting outcomes.
And all of this is interesting at like the systems level, but for someone listening who's dealing with mental health issues today, what does it mean to them?
Okay, yeah, we were kind of talking over everybody's head.
Yeah.
A few things. You're allowed to bring your whole story to the office with you, your trauma history, your social stressors, any medical conditions, your diet, your sleep, and your culture. And you would bring those to your mental health visits, even if the DSM criteria are system-based. Those roots matter for your care. Okay. You can also ask your clinician how they see environment, upbringing, and biology interacting in your situation, not just what box you fit in. If a diagnosis feels off or incomplete, it's okay to ask, how confident are we about this label, and what else are we considering?
Yeah, I know a friend of the family recently was hospitalized because they had a bladder issue. And because of that, it had a severe effect on their cognition and overall well-being. But it was, it's
when the toxins back up because of a
so you never really know what's going on. But like sometimes, so taking a whole
person approach
is truly wonderful.
Yeah.
But I think everyone has to play an active role in that. The patient, the caregivers, the family, everyone.
Not just the nurses. The nurses seem to get the handle on everything. They see it all,
right?
And they're pretty good at putting it all in one box. But everybody else,
they don't see a person every single day.
No, they don't. Yeah.
Most times they don't. And if you're a clinician, researcher, or advocate, you can actually participate in this update. So submitting proposals, commenting on drafts when the APA invites feedback, and amplifying the voices of patients and caregivers in those conversations. Get out there and you can take an active role. And I think that's wonderful. I don't know what it was like in the past, but it's it's absolutely fantastic in my opinion.
Okay.
Am I unqualified in the knowing?
Well, you're an advocate, so it counts.
Okay.
We're at an interesting moment in mental health as the DSM moves toward a more digital, living format. There's a chance to bring in what we now know about trauma, social determinants, inflammation, nutrition, and culture, and about what it's like to live with these conditions day to day.
And no manual will ever capture the full complexity of a person, but a more responsive, inclusive DSM could nudge the system towards care that sees people in context and not just as a list of their symptoms.
Yeah, this was a good episode. Well, this podcast is not intended to be a substitute for
Professional
medical advice. Go ahead, Jean.
Diagnosis or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition and before undertaking a new healthcare regimen. And never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast.
Till next week.
Thank you for joining us.